Hello friends, the topic that will be covered in this module is a challenging subject for any counselor. The topic for today's discussion is suicide prevention counseling. Suicide, or the act of ending one's own life, is definitely a decision that comes after a lot of emotional turmoil for the client, and at the same time, hearing about the suicidal death or even about the suicidal intent of one's client can be a very traumatic experience for a counselor. Many times, the news of a client's suicidal death comes when the counselor is least expecting it. It might come when the client seemingly looks as though they are getting better or are sufficiently out of their depression. It can leave the counselor feeling shocked, scared, angry with the client for taking such a decision, and also incompetent as a professional. Needless to say, being aware of the mental emotional state of suicidal clients, the legalities involved in it, and having the ability to deal with suicidal clients requires specialized training. Some people believe that people who are only trained in counseling should not handle cases where the client is known to have suicidal tendencies, but that such clients should be referred to people who have more extensive training. They believe that counseling training does not equip a counselor with the skills that are needed to really understand the suicidal client's inner world. Counselors are not well versed with psychopathology, nor are they abreast of research findings or of the legal implications for the process of counseling suicidal clients. But still, is it really possible for counselors to refer every single suicidal client to someone who is better qualified? What do you think? What does research say? Let us have a look at some research findings. McAdams and Foster conducted a survey in the year 2000 in which 376 counselors participated. As many as 1/4 of these counselors had had at least one client who was suicidal. 89 of these counselors had at least one of their clients die by suicide. Many of these counselors had experienced this death while they themselves were still student counselors. Hearing about a client's death had had a big negative impact on these counselors. This impact included intrusive thoughts, intensified dreaming, and feelings of anger and guilt. So, the answer to our question about whether counselors can avoid suicidal clients is no. At some point or the other in a counselor's life, they are going to be dealing with suicidal clients. At present, many counseling training programs do not equip counselors with the necessary skills to deal effectively with suicidal clients, but such skills need to be integrated in the curricula of counseling courses. There are several things that we have to know as counselors dealing with suicidal clients. First, as counselors, we must have a good understanding of the phenomenon of suicide, the conditions under which clients are most likely to take this drastic step, and the mental state of suicidal clients. Secondly, sometimes the counselor may not even be aware that their client is entertaining suicidal thoughts. Clients may be giving counselors hints that they are thinking of or wanting to end it all. It can be very risky for a counselor to not be aware of these warning signs. In their ongoing sessions with the counselor, the client may even assure them that they are feeling good in their life and the very same night consume pills. Hence, it is very important for the counselor to be adequately trained in the use of risk assessment techniques for the client. Thirdly, counselors must know how to support their clients when they are going through these intense crises in their lives. Many of the clients have been to other mental health professionals such as psychiatrists and also have been in and out of hospitals, but they have never opened up to anybody. The counselor, with their specialized training in active non-judgmental listening, empathy and unconditional positive regard, is in a unique position to provide the much needed care and support to these clients. Finally, counselors need to be aware of the legal aspects and the liabilities that they have when they are working with these suicidal clients. Keeping these perspectives in mind, the present module is divided into 3 parts. Part 1 deals with understanding suicide as a phenomenon. Part 2 deals with suicide risk assessment, and Part 3 deals with suicide prevention techniques as well as the ethical and legal issues that counselors might face while dealing with suicidal clients. So friends, here we come to the end of the introduction, and let us now begin with Part 1, which is understanding suicide as a phenomenon. Before we begin to discuss about suicide, there are a few terms that we should be familiar with. These are terms that appear frequently in literature pertaining to counseling. Let us have a look at some of these terms. The word suicide. Suicide is any intentional self-inflicted injurious behavior that leads to death. Please note the emphasis on the word intentional and self-inflicted. Coming to suicide ideation is basically thoughts about self-inflicted injuries or death, including plans, means and outcomes of suicidal behaviors. Suicidal threats. These are statements of intent to self-harm without action. For example, verbally threatening someone that if they do not concede to the demands made on them, the person will kill him or herself. Almost suicidal behaviors. This is another term which appears frequently in literature. Actions of intent to self-harm without actual completion. The term parasuicidal behavior refers to non-fatal intentional self-injurious behavior that results in actual tissue damage, illness or risk of death. For example, any ingestion of drugs or other substances which are not prescribed or they are in excess of prescription with clear intent to cause bodily harm or death. Non-suicidal self-injurious behaviors. What are these? Intention being help seeking, punishment of others or attention seeking. For example, holding a knife as though to kill oneself without actually cutting, or sitting in a balcony as though ready to jump off but not actually doing it. These are non-suicidal self-injurious behaviors. Suicidal self-injurious behaviors include deliberate, these are deliberate acts with the intent to die. Finally, the term died of suicide or died by suicide is used to show somebody who has already completed the act of suicide. The term committed suicide, however, implies a crime or an immoral act. Suicide is no longer seen as a crime or a sin, but it is recognized to be the result of a mental health condition. Hence, instead of using the word committed, which implies a crime, it is thought that the term died by suicide is more appropriate. However, in the current module, for purposes of convenience, we will use the term committed suicide. Who is a person with lived experience? A person who has struggled with suicidal thoughts or behaviors and may be an attempt survivor. The term bereaved by suicide. This is used to denote someone who has been exposed to the suicide of another person and experiences a high level of psychological, physical and or social distress for a considerable length of time. In the US, the term loss survivor is also used to denote the same thing. Having understood these terms, let us now have a look at some statistics about suicide. Unfortunately, every year more than 700,000 people die of suicide in the world. This is according to the report of the World Health Organization of 2020. Suicide is the 11th leading cause of death in the United States and the second leading cause of death in the age group of 15 to 24 years in the United States. This is according to the report by National Institute of Mental Health, again given in 2020. In India, 1,39,123 suicides were reported in the country during 2019, which shows an increase of 3.4% in comparison to 2018. This is according to a report which was published by the National Crime Research Bureau in 2019. Thus, we can see that suicide as a phenomenon is a matter of great clinical significance. As consumers and practitioners of psychology, we need to be aware of what this phenomenon is, how it is to be assessed and what can be done to prevent it. If we look at the gender differences in suicide, we find that males are 4 to 5 times more likely than females to die by suicide. However, females attempt suicide more, but they also use less lethal methods to die. Men make use of more lethal methods such as shooting a gun, jumping in front of a train, or jumping off a cliff, setting fire to oneself, or hanging. Whereas women use less lethal methods such as strangulation, suffocation, or overdose of medicines. What is the picture when it comes to different age groups? Suicide was the second leading cause of death in the age group of 25 to 34 years, third for people from 15 to 24 years of age, and fourth for people in the age groups of 35 to 44 years, as well as for people in the age group of 9 to 14 years until recently. But now the group that is at greatest risk is the age group of 15 to 24 years. Also, in terms of completed suicides, it is the age group of 65 years and older who shows the greatest percentage. Approximately 60% of people who commit suicide are depressed. And even among the rest of the people, a majority have one or the other mental disorder such as bipolar disorder, schizophrenia, anorexia nervosa, drug addiction, or borderline personality disorder, to name just a few. This list is not an exhaustive list, and there can be other psychiatric conditions which are also associated with suicide. We will discuss these conditions shortly. There are also certain life circumstances under which people are more likely to attempt or complete suicide. People who attempt suicide often do so under conditions of severe life stress such as intense interpersonal conflicts or soon after a breakup of a loving relationship, separation, or divorce. While among people who complete suicide, we find that elderly people, especially above the age of 65 years, are most likely. Further, if such people are widowed or are going through a serious and chronic physical illness, they are more likely to take their own lives because the pain and loneliness can make them feel depressed. Another disturbing phenomenon is that of suicide among children. Children between the age group of 5 and 14 years were not at risk until recently, but in the last few decades there have been cases of children in this age group also who have committed suicide. It is unfortunate that this rate has been increasing in the last 3 to 4 decades. In this age group, if a child has lost a parent or is being abused, then the risk of such a child attempting suicide is higher. However, the age group that is at greatest risk of attempting suicide is that of 18 to 24 years. In this age group, if a student has a conduct disorder or depression or is addicted to alcohol or drugs, then the risk is definitely higher. Students in this age group are faced with the difficult task of facing competitive academic world and making career choices. Many times, they are also not able to establish meaningful dialogues with their parents, extended family, or friends. They may also be going through other relationship difficulties, and at a point where they find themselves utterly unable to adjust to the demands of their life, they begin to look at suicide as the only means of escaping the pain. Parents going through divorce or separation can also be a stressful factor for adolescents, putting them at increased risk of suicide. Many of these adolescents are academically high achievers, but also people who have very high expectations of themselves. Usually, for some time before the suicide attempt, they may feel a loss of self-esteem, their grades drop, they do not socialize, and they may not also take care of personal hygiene. They may also feel chronically anxious and have panic attacks. While they do not socialize much, many of them communicate this state of mind to at least one friend in the form of a disguised warning. It is therefore very important to spread awareness among college and university students, to be alert to any signs of danger or suicidality among their friends, and if they notice any such signs, helping the friend to find assistance for mental health. Finally, there is one more age group that is at increased risk for suicide, and that is people who are creative. It has been known that highly creative people such as poets, musicians, actors, and painters have committed suicide in the past. So friends, here we come to the end of the first section of this module on suicide prevention counseling. In this section, we have understood some of the terms related to suicide. We have also looked at some of the statistics about age and gender differences. In the next section, we are going to consider historical and modern views which have been put forth by suicidologists. Thank you.